Perfect. Let me share my screen.
Thank you. All right, so as Jenner had already announced, welcome to the Montana Antimicrobial Stewardship Coalition call for January. We appreciate all those that are taking time to join us today. If possible, please do type your name, position, credentials, email, and facility affiliation into the chat box. This is for grant purposes, so we do actually have to track all of this information so we can get credit for hosting these types of calls and for future funding. If you are not from Montana, we do ask that you just include which state you are from because we do open this invitation to surrounding states. And then if you have multiple people joining, please do include everyone's information just so we have an accurate count of those that are attending our webinars. And then if you would like to, I always love to see your lovely faces. So if you can, please turn on your webcam. I do understand some people aren't comfortable with that, but if you are, we'd love to see you today. All right, so we are kind of cruising right along and we are in week 6 already. I do want to point out that we do have a webinar planned for next month as well. I did just send out the email to the APIC listserv. So we are going to continue doing these webinars throughout this year. It will be hosted on the first Wednesday of every month, same time. Next slide. All right, so today we're going to just do have Dr. Colucci, as usual, just do a welcome and any housekeeping items we want to review. We have a really special guest today who's going to be doing a case presentation. We also will talk about who's responsible, preparing what leadership wants to hear and understands. And then, of course, the purpose of these calls is to have a discussion at the end, have facilities share their experiences. So if you would like to share anything you are currently working on, any concerns, anything that you're just trying to work through right now, please put that in chat and we would love to hear from at least one facility today. If not, we'll probably just call on you. All right, next slide.
All right, that's the end of my slides. So we can turn it over to Vince now, and then I will ask Rachel to share her slides as we introduce her.
Okay, thanks, Jenner. Thanks, Erica. Hello again, everyone out there on this snowy Montana day. Hope everybody had a great holiday season and happy 22. Here we go. And I think we got a really good program and programmable type of process going forward. So let's build momentum and keep it up. As mentioned, Rachel Smetanka is going to present a couple different ways. She has graciously agreed to break this up into 2 components and present this month and next month because there's 2 different aspects to this case. That is, in a critical access hospital, if you had a complicated patient like this and need to be transported out or transferred out, how do you allocate the resources and what do you do while at the same time clinically managing the patient? So there's going to be one component of that. And then the other piece is going to be the actual clinical stewardship of the patient. So, from an infectious disease perspective. So, and I don't know which, I'm going to defer to her in terms of which one she wants to present first, but thank you very much, Rachel, for agreeing to participate twice. And then as mentioned, Dr. Koo will present kind of the administrative piece of it, and because that's always going to be important going forward, and we need that administrative buy-in. So I'm going to quit talking and I'm going to turn it over to Rachel.
Okay, hopefully, did my screen share, Jenner? Okay, and you guys can hear me.
We can hear you.
Excellent.
Perfect.
This is the hospitalist office. I put a note on the door. Ideally, we won't get interrupted, but there's all bets are always off. Thank you for the invitation or the peer pressure, Jenner, to present a case. And it's interesting, as this was approaching, I was trying to figure out what the best case would be. And then all of a sudden one just sort of landed in Jenner's in my lap last week. So today we're going to talk about, and I should clarify, I think unlike a lot of rural critical access hospitals, we have a full-time hospitalist program. So we have a full-time daytime person and full night coverage. We have clinic docs that cover on the weekends, but there is a hospitalist either in-house or available all the time. I think unlike some other locations that have clinic docs or shared responsibilities between ED providers and hospitalists, we are two separate entities at this hospital and separate from the clinic. So the benefit is having a hospitalist in-house almost all the time. So the case presentation for me today is a 16-year-old male with 3 weeks of fever, chills, sore throat, headache. Our hospitalist group typically is 17 and older. We'll take the occasional 16-year-old, but oftentimes 16 and under for us is covered by the family practice provider. A little bit of ED discrepancy based on the illness of the patient who's being presented. This one happened to land on the hospitalist service. Okay, so let me move some windows around so I can read my own objectives. Talking with Jenner a little bit, not understanding exactly all the components of the group when we were thinking about this case, I just put together some basic objectives. So as Dr. Colucci said, the first part of this is going to be the logistics of critical access hospital, getting somebody out, recognizing critical illness, the players and all of the resources at this particular and other critical access hospitals. Next month will be more of the antibiotic stewardship, because I think by then we'll have a little bit more of the pieces together, final cultures. And I think the antibiotic discussion is going to be fascinating in this case. Jenner and I nerded out quite a bit yesterday over this case. So I'm excited to talk more about that with the group and get some feedback. So purposes are just to generate some discussion on an interesting medical case from a critical access hospital. I always liken practicing in a critical access hospital to being a law enforcement in a small town. You see everything that exists in larger places, but in smaller volume, and this is a good example of that. Reviewing the importance of evaluating the full clinical picture and what it looks like when you actually have a critically ill patient. But that caveat is, I walked into this on a Monday with fresh eyes, which is the benefit of having a hospitalist change over when we did. Dynamics and relationships between provider groups at critical access hospitals and large hospitals, because this one really was ED provider transition to nighttime hospitalist. And I think those logistics are extremely important if you have those two separate entities as we do and larger hospitals do. Barriers of having critically ill hospitals or critically ill patients in a hospital. Again, because like a large place, we see everything, just not necessarily in as much volume. So that was the objectives I threw today, knowing that with your guys' group in the antibiotic stewardship, next month's discussion is going to be much more focused on antibiotic usage, why somebody got better, treating something we didn't necessarily know, and now we're kind of putting the pieces together as we get some data back. So again, this is a 16-year-old male, which is a little bit young for this particular hospitalist service. So he actually had a virtual visit at the walk-in clinic for fever, several days of chills, and a sore throat. He was in school playing basketball, just not feeling spectacular. The virtual visit, the concern was for strep. He was strep negative, but was given a Z-Pak for potential infection, potential anti-inflammatory properties, sent home, continued to not eat particularly well, just being lethargic, not in school. He wanted to do a little bit of basketball practicing with his friends. The basketball program here was a hard stop on making sure that he didn't have mono or anything else particularly infectious. So still had some symptoms, still not eating very well, still having some night sweats, fever, sore throat. Mono was negative so that he could return to sports, even though he ultimately did not feel much like that. Limped along for about 10, 12 days at home, drinking mostly fluids, decreased urine output, just a lethargic, sick 16-year-old. On Christmas, his parents finally just said, like, look, this doesn't look like a 16-year-old should look if he has a common cold or a rhinovirus or an RSV or something like that. So on Christmas Day, they brought him in for continued fevers, sweats, cough, headache, and a bout of nausea with vomiting. And he was just kind of flat and pale, and per his parents, just did not look anything like he should look as a 16-year-old kid. He was tachycardic in the emergency department, shaking chills. Initial blood pressure was 86/44 pre-fluid. Temperature was 102.9, which was his Tmax for the first 24 hours. He did have a leukocytosis with a left shift. CRP was 200, lactate of 5. He was mildly hyponatremic. Respiratory pathogen panel was positive for a rhinovirus. Given the respiratory symptoms, he did have a chest x-ray, which was negative for acute process. They drew blood cultures and were pending at the time of admission. The emergency provider recognized that he met sepsis criteria. I think the word was probable, but met sepsis criteria, gave him a gram of IV Rocephin, 500 milligrams of IV azithromycin, 2 liters of fluid, and called the night hospitalist to admit him for sepsis and rhinovirus. At that time, no other workup was done. So he did get a dose of IV Rocephin in the emergency department, the 500 of azithromycin. Per sepsis protocol, kept him on 130 mLs per hour of lactated ringers. Hospital day next, so the nocturnist for us signs off about 8 o'clock in the morning and the daytime provider comes on. He felt a little better, but continued to say, I just don't feel normal. Very headachy, no visual changes, a little bit congested, sore throat, not eating or drinking much at all. Urine was still dark and low in output. Parents were trying to get him to eat by bribing him with anything from the outside, McDonald's shake and Dairy Queen and whatnot, and he just didn't want necessarily any part of that. On his laboratory studies, his lactic acidosis had resolved overnight with continued fluid resuscitation. White blood cell count was down a little bit, decreased left shift, and CRP actually had dropped a bit overnight. Again, I'm imagining some of that maybe is a little bit delusional given that he'd had a couple of liters of fluid, but nonetheless, he felt a little better. He hadn't had a fever for about 12 hours and overall looked a little bit better. In the setting of rhinovirus and some clinical improvement, at that time, antibiotics were not reordered. So the doses that he got in the emergency department at this time were the only antibiotics that he had. The rest of the treatment was symptomatic in the setting of rhinovirus in a 16-year-old. Blood pressures had improved. Because he's healthy, we didn't have a ton of hemodynamic data on him from previous. Looking back at some sports physicals and some clinic visits, it really looks like his blood pressure normally was about 110/70. So he was definitely lower than the previous baseline that we had, even given the limited data. Pressures were overall better. He occasionally had a MAP of less than 65, occasionally was still tachycardic in the low 100s to 110s, up to maybe 120 when he was up and moving about, which it was hard to get him out of bed because he just felt crappy. That afternoon of hospital day 1, had another temp of 101.2, came down with some Tylenol, and he just felt wimpy. So no additional antibiotics, supportive treatment for the rhinovirus, so cough suppression, treating fevers, and just seeing how he declared. That afternoon when that his temperature spiked a bit, they gave him some Tylenol, tried to get a little bit of fluids in him for dinner. We did another shift change at about 6 o'clock that night, and the nocturnist came on, the one who had admitted him the night before. So on that night, his fever came back up. He was more persistently tachycardic, continued poor PO, and had some MAPs again that were consistently less than 65. Systolics were largely in the high 80s. Sometimes his diastolic would make him have a MAP of greater than 65, but for the most part, his MAPs were consistently less than 65. That night, one of his blood cultures popped positive for a gram-negative anaerobe, and it was a single bottle from one of 2 sets. So oftentimes when we have that happen, especially with a gram-negative anaerobe, the first thing that pops into our heads is it a contaminant? Looking at the clinical picture and trying to decide sort of what to do with that. Interestingly, in the setting of the MAPs of less than 65, he had an additional liter bolus of LR, and we broadened antibiotic coverage to 2 grams of cefepime every 8 hours, which we can talk about next month, because in that setting, if you're thinking that gram-negative anaerobe is real, cefepime probably would not have been the first choice per se. That being said, his pressures did come up a little bit with that additional bolus of lactated ringers. He was still on the baseline rate of 130. He slept overnight. The next morning, I came on as the hospitalist and saw a 16-year-old. I walked in the room. I think like other hospitalist programs, I had reviewed the notes the night before. We do a doc-to-doc or a provider-to-provider sign-out. So I walked in the morning expecting to see a 16-year-old who had rhinovirus, and I walked into a very pale, diaphoretic, tachycardic, very ill-appearing 16-year-old. And I am somebody who does not take care of a lot of ill 16-year-olds. Headache was worse, and it was largely, he said posterior, but not against where the bed would be, more of like posterior kind of scalp. Dark urine, decreased output. He's not eating and drinking much at all. His parents were starting to ask about something like TPN because they just couldn't get anything in him. And over the course of this illness, he had already lost about 15 pounds prior to his hospital admission. CRP was back up to 208. Lactate was up again just a bit to 1.1. leukocytosis. So initially at 14, down to 9 on hospital day 1, back up to 12 with that left shift. And on physical exam, tachycardic again, diaphoretic, and he had, just based on his clinical picture, I was thinking, meningitis or with that continued headache. So I had him sit up in the bed and just do some kind of chin to chest, which he could do very easily. He had a little area of fluctuance right about at his hairline on the right-hand side. And when he put his chin to his chest easily, it was a little bit bulgy and it caught my eye. I had him lay back and I touched it. And if there was a chandelier sign for males, that would have been it. I touched that area of fluctuance. It wasn't red. It had no head. He had some cystic acne scars on his back. So one of the things I thought about is maybe, is this going to turn into a boil or a furuncle or something like that? But I touched it and it was exquisitely tender. And the back of his scalp was fluctuant and a little bit spongy. And in the setting of that kid, I just thought, I just said to his parents, it didn't seem necessarily normal to me that he would have collections of abscesses or fluid between his scalp and his skull. So I told him I was going to walk down and talk to the radiologist. And because I didn't know, my CT with IV contrast was my go-to, but I wanted him to, if he wanted me to run an ultrasound over something, I thought about that as well. So I talked with the on-site radiologist. We are lucky enough that we have 4 days out of 7 where we have an on-site radiologist. We use a reading service at night and on the weekends and on Wednesdays. Other than that, we contract with the radiology group out of Bozeman to be on site Monday, Tuesday, Thursday, Friday, which again, for our critical access hospital is amazing. They will do procedures. They help out with a lot of things. In this case, it was just getting a little bit of advice on, do I need to do something other than a CT with IV contrast? So I then went to the stress lab and the radiologist called me and just said, hey, I have the results of that CT back. And whenever they call, I usually just show up in their office because it's nice to review it together. So I tried to go back and capture some images about what the CT actually looked like. But what he saw, so what I felt on physical exam was actually this odd little subgaleal abscess on the right-hand side. And what he was concerned about was this organizing kind of rim enhancing area with a lot of edema. On that CT scan, he already had what looked like a little bit of midline shift, clear inflammation of the meninges on that right-hand side, and junky sinuses. So this is a kid who probably had been brewing a yucky acute on chronic sinus infection that then ended up causing this, what they called a cerebral abscess. This is just a little picture. So this is that, like, I called it a unicorn horn, which is not the right thing to do, but it a little bit was like when he sat forward and it bulged a little bit. So at this point in time, I was downstairs, I reviewed this with the radiologist, and I thought to myself, I have a significantly ill 16-year-old. The only place I've ever transferred a 16-year-old out is to a psychiatric institution. So trying to get a 16-year-old out, our first call, just based on our referral pattern, is almost always to St. Patrick's and Missoula. So when I talked to the radiologist, this is sort of what he put as his findings and his ultimate note, so the findings on the CT scan were suggestive of meningitis, frontal lobe cerebral abscess, surrounding edema with mass effect and a midline shift, some subgaleal abscesses. So I went back up into the room and I did another full neurological exam, which was normal. He was GCS 15, no focal neurological deficits. I gave a very brief update to his father, who was at bedside, and just said, this is the kind of thing that we try to get out of the facility reasonably fast. And I sort of walked back to the office to make phone calls. So what I ended up doing was making our first call, which was to the St. Patrick's group. We oftentimes use their infectious disease consultation and or transfer if we have infectious disease folks that need to be placed elsewhere. So recognizing that he needed to get out of our facility reasonably quickly. So I called St. Pat's, talked to the infectious disease doc based on what I found, and they were, as infectious disease docs get, very excited about an interesting case in a sick 16-year-old. I felt less excited than that particular ID doc just because he made me a little nervous. He was persistently more hypotensive, just flat, again, normal neural exam, but just flat and diaphoretic, and he just looked like crap. So when I called Missoula, the St. Pat's group, the infectious disease group, actually wanted the patient, but they had a hard stop on a 16-year-old in their ICU, and they don't have a pediatric ICU. So as excited as the ID doc was, and they had a neurosurgeon who was also willing to do a 16-year-old, they didn't have a place to do anything with a critically ill patient that was 16. Happily, I did talk about the findings. We talked about that 1 gram negative blood culture. And he recommended to start that patient on vancomycin and Unison. Jenner then started making, she was on our facility that day. Jenner started making phone calls because we had a pediatric. We don't typically do loading doses of vancomycin in pediatrics. So Jenner made some calls to get him his loading dose correct. We got that hung, got the Unison hung. And then I got a second call from the lab that he had a second blood culture pop positive again for a gram-negative anaerobe, which made me think that that probably was more real than initially we had given credit to. So Jenner helped get the antibiotics hung, and I started making phone calls knowing he needed to be out. He needed to be out reasonably fast because of the persistent hypotension. His lactic acidosis was returning and he was getting sicker in our facility. So knowing he needed to transfer probably by air to a larger place, having a sick 16-year-old, it became needing a place that had a pediatric ICU with a pediatric ICU bed and a pediatric intensivist that was willing to take him, and or an adult ICU that was willing to take a 16-year-old patient who was adult size. So the first couple of calls I made, one piece of that was missing. I had a pediatric bed and a neurosurgeon that wouldn't do a 16-year-old. I had an ICU that wouldn't take a 16-year-old in an infectious disease group and a neurosurgeon that would have taken a 16-year-old. I then had a pediatric ICU with an intensivist and a neurosurgeon and an infectious disease group who did not have a pediatric ICU bed. I finally found the right combination of things, which was a pediatric ICU with a bed and an intensivist that would take them, a neurosurgeon that does case-by-case cases in kids, who said he would take and potentially drain a 16-year-old that was adult size, and they at least had access to consultation by an infectious disease group. I talked to the pediatric intensivist on the phone who recommended 2 liters of LR as fast as we could get it in. And if his pressures still did not respond, because his MAPs by then were in the low 50s, again, neurologically intact, tachycardic. So we ran in those 2 liters as quick as we could. And he essentially said, if that does not bring his MAPs up to consistently over 65, go straight to norepi. So we called, the weather was a little bit persnickety that day. So we originally were thinking we were going to have to fixed wing. We ended up getting a helicopter that was willing to fly, and they ended up flying to a facility in Billings that had all of the pieces that we needed for that particular kid. In the interim between phone calls, and there are 3 phones in this office, and there was a human on all of them on hold waiting for calls. So Jenner manned a phone and our discharge planner manned a phone. I manned a phone, just trying to figure out what pieces were going to come together, which I think most any provider that tries to get someone out of critical access hospital, especially in the setting of recent COVID issues with diversion, understands sometimes you make 6 phone calls and wait for something to happen where you can get them out of your facility. So in the interim, giving some updates to his parents, talking about what would likely happen, when that needed to happen, and getting his parents on the road in horrible road conditions to end up getting to Billings. So ultimately, when he got to Billings, I was talking with our radiologist yesterday, who was not the initial radiologist that read that CT scan. That radiologist was suspicious that the neurosurgeon would want an MRI prior to thinking about how to either drain up the nose or do a craniotomy. And I don't know that that happened because I wasn't able to get on and look at his Billings records. Hopefully we will by the time we meet together again in January. But ultimately, they did a craniotomy. He's back in the community on continued IV antibiotics for another couple of weeks. Sorry, I'm going to just let that happen in the background. So discussion points for me, I think, were, and I would love to have other people's feedback on this. And I came in on a Monday with fresh eyes, and I had a kid who I had looked at on paper over the weekend, knowing I was coming on Monday. So my piece number 1 is, what do you do when your clinical picture and diagnosis don't match? I'm sure, like me, everybody here has seen a lot of rhinovirus in that 12 to 18-year-old population. That there's nothing about this kid that looked like rhinovirus to me. So I think the next piece that comes up in places like ours is, who does the burden of a workup fall on? You know, the ED provider was like, this kid is sick, he's got sepsis, these are his numbers. Do the ED providers finish a complete workup? Or if they are busy, does that come to the hospitalist service? And the hospitalist is like, look, I'll admit him, and continuing to dig. What I was always taught, and I think what most people are taught, is if you have somebody who looks sick, and you can't necessarily find the source, you just start digging and probing. So I think backing up and understanding now what the outcome was, it's easy to say that kid probably should have had a pan scan starting with head and moving south, especially given the consistent piece of headache. Does that fall to the ED provider? Does that fall to the hospitalist? I think for us, it's almost always a combination between the ED provider and the hospitalist. Sometimes the hospitalist will say, hey, could you please do this on their way to the floor? Or I'm happy to accept them in for an admission, but could you please get A, B, or C? And so I think, again, my fresh eyes that wasn't there that day, it's easy for me to say like, hey, would you get a CT scan of his head before we think about it? Or did you stick your finger in every orifice? Because that's the other thing with sick kids is putting a finger in every orifice to make sure that they don't have a perirectal abscess that we don't see or some other fulminant something. So I think probably in retrospect, this individual would have gotten a CT with IV contrast on his admit date and probably been transferred someplace out of our ER, but that is not how it happened. We ultimately got that out. Again, navigating the ED to hospitalist transfer, we are lucky enough to have a full set of ED providers on site 24 hours and a full hospitalist program, which I think is not how a lot of rural or critical access hospitals run. So I think we feel very lucky as our groups to have each other, but sometimes there is that gray area where an ED provider will say like, hey, this person is sick and I know they need to stay and I don't yet know what's going on. And oftentimes that turns into a discussion of what do I need you as an ED provider to do before they come to the floor? Or if they are stable, do we do the rest of the workup when it comes to the floor? And that is a continued discussion for us. And I think the last piece that I'd love to hear other rural hospital providers talk about is how do you navigate resources, referral patterns, understanding, in this case, needing a neurosurgeon and an ICU and an infectious disease group, when most of the time I have a 70-year-old and I'm getting remote ID advice on somebody who can sort of stay in this facility. So that is up until the time we talk more about antibiotics, which we will, and culture data from a stewardship perspective, because I think it is going to end up being another set of interesting discussion about antibiotic use, how we cover what to do when you have a single blood culture at a time in somebody who's sick. But I would love to hear other people's comments about the case or, diagnostics, seeing him initially, what you guys would have done in the ER, how to navigate that conversation between a nocturnist and a ER provider.
Dr. Smetanka, excellent presentation there in the allotted time. That was fantastic. So, questions, comments from the group out there? Please speak up or add something in the chat. I don't know if we got anything popped up in there, Erica, but.
Hi, hold on, let me turn on my. So my name's Dr. Adam Stenseth. I'm in White Silver Springs. Can you hear me okay? So I'm in our critical access hospital. I am basically the ER provider, and we also admit to the hospital. And we also have a nursing home associated as well. But in thinking about, this is a pretty concerning case, obviously, and in a 16-year-old. I guess in thinking about it, the couple of things that came to mind right away for me was I would never have stopped the antibiotics after the first round, because clearly if he's septic, it's going to be something bad. And it's not, in my mind, it was like rhinovirus doesn't explain it. And so for me, I would have been poking around it as well to say, there's something going on that we're missing, and he's septic and not getting better. We're going to keep broad spectrum on and try to figure out what's going on. That would be, I guess, number one for me. Number two is, so I used to be a flight paramedic out of St. V's. And so I kind of know where the PICU, at least in our region, where the pediatric ICU floors are, and Benefice and St. Vincent's generally are the ones that I would just go to right away. Billings Clinic also has them, and I think they've improved, but previously it was really only those two that I would just go to right away. And so I don't, number one, we wouldn't have admitted this patient just because we usually don't admit pediatrics to our hospital. but I probably would have been on the phone right away and trying to get him out to probably St. Vincent's or Benefice, to it, knowing that I know he's going to need a PICU and go from there. But obviously a really difficult case. I'm impressed with all of the findings.
Would you, so as far as an ED workup for you, would you have scanned him?
If I would have found, well, so my first thought when you were going through it was, man, is this meningitis? That was one of the first things I was like, wow, this doesn't, there's something going on here. This is concerning. And the findings of the head, the possible abscess, that was an interesting finding. And I thought, wow, maybe he has an abscess, but that wouldn't necessarily cause sepsis. So if I would have found that or thought, oh, there's something else going on, I probably would have scanned him. Yeah.
Okay.
Especially with the headache that was continued and sepsis, and we don't know the cause. I probably would have done a chest x-ray and then maybe done a head CT and all of that. Pretty much everything that you guys have been doing anyway, with the idea that I would already be talking with an intensivist, a pediatric intensivist, to say, okay, we need to get him out of here, because we need everyone on board, like all the specialists on board, to get on top of this with him. 16-year-old septic patient, that's just at baseline for me is like, whoa, there's something bad going on, and he's going to need hospitalization, and probably for a while, actually. So,
yeah.
But once again, we're pretty limited in what we can accept to the hospital for admit, and so we wouldn't even have admitted him anyway.
Okay.
But yeah, I probably would have done a little more work before I sent him.
Yeah, I think that's again, and it's so easy and after the fact. And I walked in Monday and he just looked like just crap. So I think it's easy to armchair quarterback, but I think from my perspective, again, we don't see or keep a lot of sick 16-year-olds, and to have his numbers and his lactate and his hemodynamics and a diagnosis of rhinovirus like that never went together for me, even when I was kind of chart stocking for AFAR, just in preparation for the shift. And I think we actually have had a couple very sick young people recently. And I think it's always a good reminder for me as a provider that if it doesn't make sense, man, you got to go looking. So I think I'm with you. I think one of my colleagues, I think, is on here, Lena Dickerson, I think was going to be on. I guess, any thoughts just because you work in the same facility?
Yeah. Hey, Rachel, this is Lena. Great presentation, by the way. Thank you very much. Also, I'm just curious, maybe I missed this, but was there ever a spinal tap done on this patient?
No.
There was. What were the results? And also, I guess, like, if I had that patient, I'd probably tap them, just because with the headache, not only, I mean, I probably would do the CT, the head CT, and then I'd probably tap them. Maybe simultaneously, maybe one before the other, but I don't think I'd delay the antibiotic initiation before doing that, but I'd certainly want to do that as quick as possible, because, again, as it was already stated, that's kind of high on my differential.
Yeah.
But was it ever done? Was there ever?
Nope, it was not done. CBC metabolic panel, respiratory viral panel, and a chest x-ray, antibiotics into the fluids, antibiotics into the floor. Like, it was a really pretty brief. And I think, like, practicing with you, knowing how you practice, my guess is you would have scanned his head probably before I even had looked at his chart. And I think the reality is that I think that probably would have set a different ball rolling. But I think the point for all of us, I think, is early recognition. And then I think from, like, places that do keep sick people or don't keep sick people, recognizing, sick 16 does not exist here very often, and keeping, I mean, he should have gone out from the ER. So I'm grateful that we had a positive outcome to have some learning lessons amongst the medical group here, but it still scared the crap out of me.
I think the last thing I wanted to add too is that the sensitivity of a chest x-ray in the setting of pneumonia is so low that, like you said before, pan scanning this patient would have been entirely appropriate if you were looking for a source, especially with 2 weeks of symptoms. and maybe even doing a quick bedside ultrasound of heart and lungs as well.
Mhm.
If I may, let me chime in, since I may be the only ID doc on this whole in this whole group here. So I trained at a large university-based medical facility, and certainly working here at Billings Clinic, we're the largest referral center in the area. So I do get a fair number of calls referring, cases similar to this, and this is a fabulous case. This is a great case for fellows to work out. But there are things that kind of come to mind, and it is one of the challenges I'm hearing from you is that you're a small facility with limited resources. You don't have the luxury of all the fancy all the equipment, as well as all the appropriate medical specialists. So you're there to in a lot of ways, for the size of your community, it's adequate. You don't need a very big facility. But on the other hand, when you get those occasional more complicated patients, not as well capable of managing those patients, which is what we come into play. Now, some of the thoughts as you're kind of going through the case, and some of the things I'm hearing from everyone else is that certainly is the question is when do you call for help? Because that's kind of going to ultimately is kind of the underlying issue that that you're experiencing is when and how do I do this? And then certainly who will take it? I mean, there is that challenge. That may be something I can help to some degree, but not all the way. But if you're calling for an ID doc to figure out what's going on, the first thing we're always going to ask you is not what antibiotics you need to put the patient on, is what's going on with the patient. And because certainly is that if the more information, diagnostic information you can provide us, the better we are at able to tell you where to go next. And that's where, when we get these referrals, that's our biggest challenge is because when it becomes a big scramble of trying to still figure out what's going on. And I totally understand that if you have a patient who's sick, you got to get them you got to get them to somewhere that they get the appropriate medical care. But there's that fine balance between finding out, do they really need to go? Because obviously in this case, there's probably parents involved. We got to drive them or send them over somewhere else. We're going to take care of them. There's a lot of expenses involved and things like that. So it's not as straightforward, and not hearing from the patient end, and family end that I hear that, oh, that was what it was. Wow, why do we have to come all the way over here to address something so simple? Why couldn't they figure it out? So now, and I'm not here to kind of criticize what you did, but this is what we hear sometimes on our end, is that people get transferred to us for something very, very simple. So workup is really important, and to determine where it goes. And that's where it gets really challenging is because, you got the ED whose job is really to triage. That's all they're really there to do. They're not there to work up the patient to the degree that we all feel satisfactory. And I speak from having been work as a hospitalist for 5 years. My frustration from the ER, I have no love for them. Sorry if there's any ER docs here. Because it's like, you're calling me for what? So you get that. And so you're handed this kid with who has something, you don't know what's going on. They just pass it off to us. So and you're hoping that you're just kind of tuck the kid in, especially if you're a nocturnist. Your goal as a nocturnist is to tuck the patient in for the daytime hospitalist to manage. So, but in this case, you can't really do that. You got a really sick kid. So the ER's now only doing enough to determine if this patient needs to be hospitalized. That's all you're going to know. Then your job next is where to go. And then I don't have a really good answer for how much. The question that you ask is how much should the ED do versus how much you're expected to do as a hospitalist. And that's usually something that you negotiate for each facility with the docs. Really, that's really comes down to the play. I bring this up because then I'm trying to include antibiotic stewardship into this. what you're going to do for the patient is so dependent on what you know about your understanding of what's going on with the patient. The more you know, the better you are at determining which antibiotics. And I've heard from Dr. Stetson that, oh yeah, I would put on a broad spectrum antibiotics. And I'm not saying that that's wrong, but the issue is not broad, but the appropriate antibiotics. So if you do have someone who you suspected of having meningitis, you're not going to put them on Zosyn. All right, so you still have to have an idea where you're going with the patient, and that's so my emphasis is for this is that workup is much more important than trying to dump as much antibiotics on the patient as possible. You could get to at least to a ballpark, but if you're considering meningitis, Zosyn's not going to cut it. You're going to have to be on ceftriaxone. So keep that in mind as you're as you're deciding which antibiotic therapy regimen to place your patient on is what you're really addressing. That leads to the second part is the anaerobes. Gram-negative anaerobes typically are not, it's a hit or miss. And it depends and on the context. If you have someone who came in who is pretty healthy and for some reason the ER gets a blood culture and you get an anaerobe, you probably could reasonably say it's a contaminant. But if you get someone who's pretty darn sick and you get that, you probably have to take that more seriously. So that's and this is again, trying to incorporate the antibiotic stewardship. This is where then I would actually kind of broaden the coverage, but mainly because when I start thinking of anaerobic gram negatives, I start thinking gut. And that's where probably the next step is as our workup expand, you'll have to kind of make sure that, go with what you know. So if you see that, you definitely, I mean, you may not pick up that on the day of admission, but if your blood culture came out that quickly positive on the next day, I would start scanning the gut just to make sure they were not missing something there. And it's so those are some of my thoughts in this as an ID doc. Diagnosis is much more important, and this is actually one of the reasons I wanted to emphasize is it guides your antibiotic therapy, and it's not antibiotic stewardship is not saying not to use antibiotics. It's using the appropriate antibiotics, and in this case, that's what finding the at least a ballpark will help guide to make sure so that this kid doesn't get sicker. So so those are some of my thoughts.
To your point, Dr. Koo, I think in this particular case, we have a reasonably new nocturnist who I think, gets a patient with a diagnosis from an ED provider. And I think in that way, the ED provider is an MD and the new nocturnist is a PA who I think, in building her clinical confidence to say, I don't think that that's this kid's diagnosis. I'm going to keep going. But interestingly, in a 16-year-old, when you got one culture back that was a gram-negative anaerobe, to not cover the gram-negative anaerobe, which we can talk about next time, but the choice was cefepime. So talk about coverage.
Yeah, definitely. Now, when should you call for a specialist? I mean, no one's going to, you may get grumbling, depending on who you call, you may get, but on the other hand, I would say from my standpoint, the more information you can provide me, the more helpful I can be to you. So, and that's where a lot of the times I get these phone calls. It's like, if you didn't do the XYZ things, then I can't tell you. So, because that's usually the question I always get is, what's the right antibiotic? I don't know. If you don't know the diagnosis, I can't tell you what is the best. So that, and of course, if the answer, what you're struggling with is that I don't have the equipment or I don't have the capacity to do the appropriate workup, then that's another story. And then you just have to say that, and then I'll nod my head and all right, I'll give you my best shot, and then we'll focus on when you get to patient transfer, we'll focus on the diagnosis once they get to wherever you send them to. So. But those are some of my points I would suggest. I mean, is what, as you're kind of working up when you get these really weird patients and you're looking for help, and most of you, I'm sure, are already aware, you can kind of sense when you see the patient, okay, this is a lot more complicated than something I can typically manage. And so that's usually not the problem. It's the okay, what do I do next, and then where do I send these patients? And as for the referral, that may be something, at least from other docs in Montana can, or at least healthcare system can set up a much more or easier referral center, because you had to look around for where to send this kid. I mean, you have no idea. So I think that's something that I think the state, and I don't know whether the hospital association as such can make it easier for the critical access hospital to make those appropriate referrals, so that you don't get sent all over the place and spend 2 or 3 hours trying to find whoever is the right place to send your patient.
Yeah, those are great points. Rachel, you brought up a good point, and Dr. Koo, that was kind of a really nicely worded perspective in terms of what kind of led to my question. Do you think the trigger point, Rachel, was appropriate? Obviously, retrospectively, but do you think it was appropriate of when an ID consult would have been, could have been, should have been called? I mean, looking back, so do you think that in terms of getting ID consult and more expertise involved in the quote unquote diagnosis of it, or you think, was that trigger point appropriate, or looking back on it, would you think it would have been sooner?
Gosh, it's such a hard question to answer, because I think the reality is the fact that kid got out of the ED without a scan of any kind, I think is so, ignoring that piece. I think that first night with fever, with low MAPS, with a gram-negative anaerobe in a sick kid, I think that's when the phone call should have happened.
Right.
But then how do you call someone like Dr. Koo and say, hey, I have not done any workup on this kid. Can you help me with antibiotics? So I think the reality in that piece was that should have been recognized as, this kid is sick. I've got a weird blood culture. I need to go digging for a source, and then call, again, brought in antibiotics, yes, not brought in antibiotics, but at least cover what the blood culture has come up for in a sick kid, do the workup, and then call ID.
Now, with that being said, I mean, in an ideal world, I would, the more information is the better. But truth is, sometimes you're pressing for time too, as well. So you may not have the luxury of doing all the testing that we would like.
Yeah.
I mean, but I think that keep in mind when we're getting these calls, we have not seen the patients, and many a times your medical records don't synchronize. We can't access yours, so I can't access any of your records to give at least to give you a better idea. So the only thing I could tell you is based on what you tell me, and that's where the challenge comes in. So it become a guess a lot of times from our standpoint. So calling early is never a bad thing, but on the other hand, if you need to, where to go next for testing, that's great. We may offer some recommendations, but knowing when to send the patient is also just as important. If you're going to do that, then do that earlier on than later, too, obviously, and alleviate a lot of the frustration on your end, and as well as on our end, because what should you do next and such while your patient's crashing, so. And that's hard. There's no magic algorithm. I mean, you just kind of have to. This is from experience where you're going to learn where. Okay, yes, next time I'm going to call sooner. Now, as for your nocturnus versus ED. Just because the ED makes a diagnosis doesn't mean that's the right one. If there's a message that they take, I speak from experience, about 50% of the time they guess wrong. All they need is a diagnosis to get their patient in. So it's still, unfortunately, up to the hospitalists and everyone else involved in the care of that patient to actually determine the right diagnosis. So a lot of times we get called, we end up having to change the diagnosis and it's commonly not the same as what they were admitted for, because that's, their goal is to triage. Their goal is to find out if this patient needs to be in the hospital or not. And then it's us to kind of determine. So kind of keep that in mind, is always see a new patient with a new definitely a new pair of eyes, but also a degree of skepticism that may not be what it is.
Yeah. And I think, the lucky thing for us, I think our nocturnist too is a spectacular person who's going to be turn into a spectacular provider. What I said to her as she was going down that road of beating herself up for not doing X, Y, and Z, to be able to learn those kinds of lessons in the absence of a truly bad outcome, that is a gift. because sometimes the worst lessons we learn is when you have a truly bad outcome. So to learn that she recognized that it didn't look right, but then I think felt a little bit logistically stuck between, you know, being a reasonably new PA and having this more experienced MD. And then here I am, you know, who do I call? Who does she call for backup? Does she call? Yeah, it was such a good set of learning lessons. I think for our group as a whole, for the logistics between our group and the emergency department, for a new provider to, you know, because it's hard to teach somebody what sick looks like. So it's like, she recognized sick. And then I think it's like, you know, using your confidence and using your experience to be like, how do you be the best advocate for your patient where you see something that doesn't make sense? So it was such a good set of lessons to learn in the absence of a bad outcome.
I think this, if your facility holds an M&M conference, morbidity and mortality, this would be a perfect case to present because it identifies systems issues. You point them out, and I think that's something that for all the facilities, they should at least have a M&M like once every few months to identify system issues, because we keep thinking about it as something someone did wrong, but a lot of times this is partly also a systems issues as well. So part of antibody stewardship is to address systems issues. So yes, should this kid been on appropriate antibiotics? Absolutely. Rhinovirus doesn't cause this. This is a really weird presentation. So yes, here that should have been on antibiotics. Maybe not, could be broad, yes, certainly, but to make that initial, and then to blow off the to say, oh well, this anaerobe, is that really, that's real or not? I don't know. But in this case, I think that now we have lesson learned.
Yeah.
In a sick kid, you got to take that seriously.
And I think back to the provider that spoke earlier from White Sulphur, or even for us, we are so lucky to have a fully staffed hospitals program and a fully staffed ED that is not the same set of providers. Because I mean, if there's 7 patients downstairs and you have this kid upstairs that needs to get out, I mean, we really are lucky. So like thinking back to that provider that was from White Sulphur, or if you still work in a place where the clinic docs come over at noontime or after work to round on hospitalized patients, the time delay potentially of getting out somebody who is this sick just based on the logistics of the system that you work in. I feel incredibly grateful.
I look forward to what happened to the kid next time we
Part 2, Dr. Koo, part 2.
Part two. Yeah. So I'm going to kind of jump in. This great conversation, great presentation, and really good feedback. Thanks for everybody out there. We're just kind of running a little bit short on time, so I know, Neil, next time I'm going to want to bump you down the road for since our hour is up here, and I want to be respectful of everyone's time and so on. But it's a great segue into next month. So obviously stay tuned there. And the only question I would throw out to you, Rachel, is in terms of getting all your resources together. And this kind of goes back to Dr. Koo's point about systems and systems approaches and algorithmic approaches in a case like this. In reviewing that, would you have done anything differently in looking back with regards to the transfer? Would anything there have made it easier for you trying to allocate or line everything up? Or was it, the best that you could do in the situation at that time, and there's really no remedy to cover all of those, all those bases other than what you had done at that point in time?
Yeah, no, I think it's good. And I think Dr. Koo made this point. It's nice to be somebody who lives in Southwest Montana and practices at a rural access hospital. I get so used to our common referral patterns, which is surgery goes here, infectious disease goes here, but the reality is, I think for me, it was making sure that I know if I get another sick 16-year-old, that kid, like I don't call Missoula for that kid. I don't call Billings Clinic for that kid. I like knowing from me, when you get those sort of at the edges of what you normally see, what is, because I would have, like knowing what Dr. Koo had mentioned, knowing that I would have made so many less phone calls because I would have known who has ID, pediatric ICU, and a neurosurgeon that would touch a 16-year-old like that. And we actually talked about that as in our group, is because we all said the same thing. Like, I've never had to ship out a really sick 16-year-old. So knowing that his age, even though he was an adult size, his age limited all of the places that I normally put a critical care patient.
Yeah.
So I think from me and from our group, like we've got all of this, you can't see it. We've got all this stuff behind us about who do you call for this? Who do you call for this? But I think from my perspective now, I'm going to add to that list and say, if you have a kid, like don't call Missoula if they're critical. Don't call, maybe if they're going to stay in the facility to get some infectious disease advice. But as far as like, if I'm going to transfer a 16-year-old, I'm not going to call the first 4 places I called last time.
Right, but a good idea in terms of bringing up a systems approach.
Yeah.
If you're a critical access hospital, a systems approach to situations like this, and an infectious disease, and where do we go and how do we do it so that everybody's kind of on the same page. I think that's a good item on your quarterly M&M.
Yep. And then I think interestingly with everybody in COVID, like so many of the referral patterns changed when like divert here, divert here, divert. So many places didn't have any beds. I think that sort of turned it all into a mushroom cloud for a while.
Right. Sure.
Yeah.
Really good.
You
Excellent, you guys. I think we're kind of out of time. So thanks for everybody joining in. Erica, do you want any final notes before we sign off?
Yeah, so just a reminder, our next call will be on February 2nd from 11 a.m. to 12 p.m. Sounds like we're going to have kind of the same crew back. So really excited. This was great discussion today. This is, I think, exactly what I know when Jenner and I talked about MASC and what we wanted it to be. This is exactly what we imagined. So thank you so much for taking the time to present today. We so appreciate it. Jenner, thanks for doing some peer pressure. You know that I'm going to approve of that. And then Vince and Dr. Q, anything from you guys?
Erica, could I throw out a comment?
Yeah, go ahead, Peggy. We've got a couple minutes.
Okay, this is Peggy Shumsky. I'm a infection control in Ennis, but I've been a nurse for 34 years and done critical care for 13, 14 years in ER. In big facilities. I've been a traveler and blah, 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 blah. So my thought is that we really need to, and I don't know, maybe there was some, but I just think that nursing needs to recognize that also that, their eyes and ears, I would hope that a nurse would also recognize that this patient is not doing well, and to be, a patient advocate to say, these are the things we're doing, but they're not working, and to be a loudspeaker, whether it's the middle of the night or the day, and to just pipe in and say, what they're seeing also. So I would just hope that we would, educate our nurses to speak up, and then also to be heard if a patient isn't doing well. Especially in a COG where resources are so limited. Thanks.
Thanks, Peggy. Speaking of next month's presentation, maybe if some critical access hospitals, I think this is really applicable to a lot of you. If you guys want to kind of next month as a homework assignment, bring what your guys' plan would look like and start thinking this through. And what do you guys do if you had a really sick 16-year-old come in? How would you guys respond to that? So I'm going to give you homework, but I think, start thinking about it and say, next month it's okay to say, we don't have a plan, but we're working on it now, right? It's okay to say that you don't have a plan, but you're working on it. But I think really something to think about, because I think any of our cause that this could happen and it would be concerning. So just gonna throw that out there too. Any final comments, questions, anything like that?
Rachel, thank you so much. We super appreciate it.
All right, well, we'll see y'all next month. In the meantime, if something comes up, you guys have questions, you're always welcome to email our group and we'll definitely get your responses back.
Thank you.
All right, bye y'all.